Hello and welcome to Up to Thrive episode 20, part 3 of what I'm calling the Libido Chronicles.
Welcome to Up to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
Man, it's a hot one today. Oof. I'm not sure how long I'm going to last out here in the sunroom. I don't have air conditioning in the sunroom. So yeah, it's kind of early on a Saturday. It's again a cracker day, but it's a scorcher. We're going out on the river today. I'm very excited. Yeah, so I think we're just going to get right into it so that I don't have a heat stroke out here. I'll just maybe mention about the title. I am well aware that I have changed the title 3 times of a 3-part series. But you know what? I can, because it's my podcast and I get to make the rules. So today it feels like Libido Chronicles just fits. And this is the final installment. So I am truly ready to get on to talking about lots of other things. I have so many things on my list of things that I want to talk about. In fact, I might just mention something really exciting at the moment. I've sent out to some of my closest girlfriend female GPs to have a look at what I have created. It's a little what I'm calling the menopause assessment tool. And I'm going to put it out there free for women to just put their details in. The details get kind of erased every time, it gets used, but it generates a report. It comes back to the person who put their information in. So for their own personal use, they can actually use that to go to their GP and to guide them in the discussions around what is happening for them, through this midlife period. So these consultations, so I've been doing the menopause clinic now for a few months, I think, and I'm still kind of working out the bugs and how it's going to work. And I think probably I'm giving way too much information in one consult. I've made the consults quite long, so they're about 45 minutes. And we do touch on a lot. I do give written information to take home that I've created about things that we talk about, and we make a management plan. We look at all the kind of chronic disease risks. We look at what their intention of coming to the clinic for, what do they want to get out of the clinic? And often they're coming either for education, they want to know what they can be. I'm just loving that these women are coming because they are proactive. They want to work on their health. They often want to feel better. So they're, coming from that real intrinsic motivating rewards place, which is just brilliant. I'm just absolutely loving working with all of them. So they come for education. They might come because they're hoping to get some help with the symptoms. And, so we go through all the things. And from my perspective, I really want to make sure that we're covering all the chronic disease risks, that we've got plans, that we've done a cardiovascular risk assessment. We've done a bones health assessment. We looked at all the things, right? And I've just made them aware of all the exercise recommendations, all the things that you can be doing to feel better, and the things, that we really need to be doing. Recently, I put a post on Instagram about, I was in the gym and, most often there are some women in there, and I just love you girls. I love seeing you in there, building your muscles, in there, pumping the iron, because it doesn't have to be the iron in the gym. I am totally aware of that. You could be doing this at home. You can be doing it with resistance bands. You can be doing it with TRX. I don't know. There are other ways to do it, but I would really love to see more women in the gym. Just would love to. Anyway, so on this particular day, there were several men in there. I was the only female. And, I just got to thinking about this risk of hip fracture. 1 in 3 of us over the age of 65 is going to have a hip fracture compared to those men, 1 in 10 of them. So I got on Instagram and I just put this little message out there about, come on girls, we really need to be taking this seriously. Like right now, at any stage, really, it's not too late to get started and start really strengthening up those muscles, getting those bones strong, protecting your future mobility and vitality and independence. Anyway, so I digress. So that's all part of the menopause clinic. And coming back to the tool that I am hopefully in the final stages of perfecting. I want to make it really useful to the GP as well. So that's why I've sent it out to my girlfriends, give me some feedback, be really brutally honest. What do you need? So that when they come to the doctor already has a lot of that information, because as I said, I'm spending a good 45 minutes. The nurse is already spending time with them before I see them, and she's collating some data for me to save me some time. But it's still taking a lot of time for these visits. They do take a lot of time, and sometimes you're going to need multiple visits to make sure that you're covering all the bases. But this document, from my perspective, is to help guide you both and maybe also give you an idea of, the things that you can be doing. So you can see what the recommendations are. You can see what contraindications or reasons you should not be taking hormonal treatment, all of those kinds of things. So you kind of have that awareness before you go in. Anyway, I'm really excited about it, and I'm hoping to have that up in the next little while. I don't know. It's, again, this is, obviously I'm very passionate about what I'm doing and really want to be as helpful as I can in this space. And I've created this myself. I've written the programs, and, you probably know by now, I really enjoy working that brain of mine and learning new things. So it's been really fun learning. Anyway, so hopefully to have that out soon. So how about we finish up the Libido Chronicles with this part 3, and then we can get on to some other things that I've got kind of in the pipeline. So as I said, part 3, what I'm calling the Libido series, the Libido Chronicles. And in this episode, I'm going to talk about what can be done if we've ticked all those boxes and done all those things that we've talked about in the previous 2 episodes, and we're still not happy with our libido. So we fixed our underlying relationship issues, including the toxic pursuer-distancer cycle that we talked about. We've opened up communication around what things might improve libido. So I've talked about that in the last episode. We've investigated, identified, and managed medical issues, including vaginal complaints, if there's any of those. We've managed mental health issues, if those are present. We've explored with our doctor any medications that we might be taking that could have an effect on our libido. And then last but not least, and so important, that we are practicing a healthy lifestyle. So good nutrition, exercising regularly, good sleep hygiene, managing our stress. Okay, so we've done all the things, and if our libido is still impaired and this is distressing for you, then you're very likely to meet the treatment criteria for something we call Hypoactive Desire Disorder. Now, I have talked about this in previous episodes, HSDD. I'm just going to touch on it again. HSDD is defined by the International Society for the Study of Women's Sexual Health as either a lack of motivation for sexual activity, or a lack of desire to initiate or participate in sexual activity. Now, that has to be accompanied by clinically significant personal distress. It has to have been present for at least 6 months. It's probably worth knowing there are different subtypes of HSDD, so it could be lifelong or it could be acquired. So often in midlife, it's something that is acquired. It's happened more so over this time period. Now, if you look at published statistics, they're going to tell you that for midlife women between the ages of 40 and 65, the prevalence, so how often it happens, is around 30%. In the general female population, they're going to tell you it's around 12%. Now, in my experience, it is very much the exception to the rule for a woman in this midlife period to not have issues with a decrease in libido around this time. And a good portion of the women who are affected are distressed by it. So I'm not so sure I'm completely buying that 30%, but that's what you're going to find printed. And who am I to argue with actual research, hey? All right, so if you do meet the criteria for HSDD, and if you are a post-menopausal woman, so you had your last period over 12 months ago, and there is no other good reason than menopause for your periods to have stopped, so we're sure that this is what that is, then one of the treatments that could be available to you, depending on your medical history, again, this has to be in discussion with your doctor, and they need to do that work to make sure there's no reason why I shouldn't, but is testosterone therapy. This is one of the therapies I promised you back in part 1 of the series that I'd be talking about. Now, I am making the distinction here about being postmenopausal because at the present time, testosterone therapy is only recommended for libido in this group of women. And we're going to talk about why that is today. Now, before we get into the conversation around testosterone, and I'll even share some of my experience, I wanted to touch on what else is available or is recommended for this issue. Now, as with most things, could surprise you, doesn't surprise me, but CBT or cognitive behavioral therapy is an option. I have talked about many, many times how our brains are just so incredibly powerful and they can cause us a lot of often unnecessary suffering. We can have thoughts we just take as the truth and never think to actually challenge them, when in reality, it's really just one way of looking at things. There could be thoughts that are just as true that actually serve you rather than make you suffer. Now, I am talking generally here, but in any event, it doesn't surprise me that CBT is a recognized option even with HSDD. I'll often talk to patients about seeing a psychologist or a counselor about, something that's going on in their lives. And the majority of the time, I think that what they see in their mind's eye is, those old-fashioned sitting or lying on the couch with the psychiatrist, taking notes and just listening to you talk, going over and over what's happened. And they don't see how talking about it can make anything any better. Now, I do want to say here that I can't count the number of times that people have come into my office and just kind of dumped it all there, what they were going through, what was happening, and then later, when I followed them up, tell me that really it was just what they needed, just to come into a safe and confidential space where it didn't really matter what they had to say. So the other person wasn't going to be, affected by what they were saying. They could just get it out. They just felt so much better just by dumping it out. So that is one thing that can be beneficial. But I also think the real magic comes from a skilled practitioner who can not only hold that safe space for you, but help guide you to show you where the thoughts you're choosing to have are not serving you. Okay, so to help you change your perspective, to help you heal. There really is something powerful about getting whatever is going on up there outside of yourself where it can be clearly seen and where it's not so easy to intellectualize or rationalize or spin in unnecessary drama. It's like cleaning house, and sometimes we've looked at the untidiness for so long, it's overwhelming, and it's hard to see even where we're going to start. Okay, so yes, you can see how highly I value this work, and I can see why it is recommended for so many things that you probably wouldn't even think of, like insomnia and here with HSDD. And then there is pharmacotherapy or medication. Now, there are two medications that exist for the treatment of HSDD other than testosterone, but they are not available in Australia. Okay, but I am going to mention them because we do have listeners overseas that would have access to these medications. And if you're in Australia, you probably may be a little bit interested in what they are and how come we don't have access to them here in Australia. So they're called Bremelanotide, or Vyleesi is the brand name, much easier to say. I might stick with that. And Flibanserin, or Addyi, again, much easier to say. These are the two medications that have been developed especially for HSDD in women, but I will say premenopausal women. Addyi was originally trialed as an antidepressant because it works on specific serotonin receptors in the brain that regulate mood and emotion. And the idea was that by working on these receptors, we can kind of rebalance our neurochemical systems that may have been reducing our sexual desire. It has to be taken every day. It takes time to build up so that sexual motivation and satisfaction improve gradually. It helps about 50% of women who take it, but it can take up to 8 weeks to start to see the benefits. So I wanted to kind of have a look and see, well, how well do these things work? Because that was one of the things that I had heard, that they weren't especially overwhelmingly effective. The best statistics that I could find was that it increases satisfying sexual events per month by 2 compared to an increase of 1 per month in those that they compared against placebo. So it looks like with this medication, you might get about 1 extra satisfying sexual event in a month. And that was the best I could find. The other studies reported kind of less than 1 in a month. The trials show that it works about the same in postmenopausal women, but it's not currently FDA approved for that population. Now, the next one was Vyleesi. That works on specific receptors in the brain as well to increase sexual desire and encourage a more positive emotional response to sexual stimuli. So make you more open to joining the party. It's an injection. You have to give it to yourself about 45 minutes before you think you might be engaging in sexual activity. You can only have 1 dose within 24 hours and no more than 8 doses in a month. The most common adverse effects were nausea, flushing, and headache, and it shouldn't be used in women with high blood pressure or cardiovascular disease, and is only licensed again for use in premenopausal women, not for postmenopausal women or in men. Interestingly, Vyleesi didn't show any change in the number of sexual satisfying events per month. The approval was actually based on the results of 2 clinical trials that did show significant improvements in sexual desire and reductions in distress around low sexual desire in the women treated with the medication compared to those with placebo. The data in terms of response to both of these drugs is, it looks to me, pretty underwhelming. And they both have risks like any medication, but interestingly, it actually took Addyi 3 goes to get approved through the FDA. And then when it finally did get approval, it was later decided it would have what's called a black box warning. So that's a significant warning that in this case, it shouldn't be taken within a couple of hours of alcohol use because it can drop blood pressure dangerously low and cause fainting. The black box actually gives 3 recommendations for when it should not be taken. So the alcohol one, and if someone has liver impairment or if they're taking medications known as what we call strong CYP3A4 inhibitors. Really, I'll just give you some examples of what that means. So there are a few in that class, some antibiotics like clarithromycin, erythromycin, some heart drugs, diltiazem and verapamil, antifungal medications like itraconazole or ketoconazole, and the HIV drug, ritonavir, and then also things like the herb that can be bought over the counter, golden seal, and then grapefruit is interestingly a CYP3A4 inhibitor as well. So Australia's not followed suit, and these medications have not been approved, and I can't see any evidence that there is any chance that they're going to be. Now, a few years ago, there was a drug undergoing trials here in Australia referred to as BP101. It sounded really promising and easy to use. It's a nasal spray. But when I tried to track down the trials to see where it was, there hasn't been anything reported since 2023, so I'm not sure exactly where it's at. One of the main investigators on that was Professor Susan Davis, and maybe one day Susan will have some time for us and maybe we can interview her on this podcast. That would be amazing. So I'll just send out a little request there. We'll see how we go. Now, one option for women who are struggling with their libido is just perimenopausal, menopausal, if they're on hormone replacement or are candidates for hormone replacement or menopause hormone treatment. One option is just optimizing that first, because sometimes just by adding in a bit of estrogen and progesterone, or estrogen if you don't have a uterus, this might help the libido, as well as some vaginal complaints of dryness and painful intercourse as well. Then there's another medication called Tibolone. Now, this is a form of menopause hormone treatment, MHT, and this can be used for the management of what we call the vasomotor symptoms, so, hot flushes and night sweats that are associated with the menopause, and also can be used for the prevention of bone loss. It can be considered for those post-menopausal women who would like some help with their symptoms, but also, libido might be an issue. So then you kind of get a little bit of help with all of those at once. It does have some effects on lipid or cholesterol metabolism. And so we're not really sure what the long-term effects of Tibolone is on breast cancer and cardiovascular disease. So we've got to keep that in mind. And it's certainly not recommended for women who have a history of breast cancer or heart disease, and should, again, like all hormone treatment, really be used with caution in women over age 60 because there is an increased stroke risk with this medication. So those are some options. Now, after a few months, if we've started the MHT, we've given it some time, it's been a few months and the libido is still an issue, then that's probably a good time to have a discussion about testosterone. Now, it doesn't have to go in that order. That's just one order. You can go right to testosterone for HSDD, but again, if you have those other symptoms, it's worth treating those because they could be partly to blame. And so then if they are, then it really isn't HSDD because there's a reason for it. So it is worth treating all of those other symptoms before you get to the testosterone. But if it is just the libido, then you can jump right to the testosterone. I hope I'm not confusing this issue, but the other thing to make sure that, you've added in some vaginal estrogen, you've either started with that, if that's the main complaint, or those vaginal complaints, or after a few months of your MHT, if you're still having vaginal complaints, then you can add it in. Then you can see here there's lots of variables and lots of kind of troubleshooting. And this is why you need a good relationship with your doctor, and it might take several visits to get this right? Okay, so in Australia, really, the only drug therapy that we have on our guidelines for HSDD is testosterone. And I had said earlier that it really is only for postmenopausal women, and that's because there isn't enough evidence for premenopausal women yet. I think that there, is enough evidence that you could consider it in premenopausal woman. That's a conversation you need to have with your doctor, and some variables to discuss around that. It doesn't mean that women can't have it. It just means that we don't have enough evidence yet to support putting it on the guidelines, right? Sadly, for premenopausal women, there isn't anything in the guidelines for HSDD. For postmenopausal women, there's enough evidence that testosterone therapy has actually been endorsed by the Australasian Menopause Society, and there is a global consensus statement. So that means that experts from around the world in this area have gotten together, they've agreed on when, why, how, all the things, and they have put together some guidelines for the rest of us to follow, which is really cool. For testosterone, the studies consistently show an increase in satisfying sexual events by 2 episodes in 4 weeks, an extra 2 episodes a month, compared to placebo groups, which consistently came in with less than 1 extra sexually satisfying episode in a month. So there is some clear evidence to support it, which is great. Now, it was first approved in Europe to treat HSDD for women who had gone through menopause because they had had their ovaries out, so what we call a surgical menopause. And then, as I said, it's approved here in Australia, but it is still what we call off-label treatment in other countries, meaning that it can be prescribed, but that you're using it for a condition other than the condition that the medication has been officially approved for. We are the only country to have an approved testosterone cream being manufactured for women. Other countries are using testosterone made for men, and that risks giving us way too high of doses. Because of the differences in the way our bodies absorb medications, oral testosterone is absolutely not recommended because we could end up with very high levels, what we call supraphysiologic levels. And these levels can get so high for a woman that they can actually cause problems with cholesterol and your heart and your liver. So absolutely no oral testosterone should be taken by a woman. Now, you may have heard on the internet, I've seen a bit of this on the internet about testosterone pellets. So testosterone pellets are one form of testosterone therapy, and I think in the States they're being used a fair bit. They're not specifically approved for women, and they're often what we call compounded. So we've talked about compounding way back when in earlier episodes, where the chemist or the pharmacist makes up the medication. So it isn't regulated. There's no way of being totally sure how much of the active ingredient is actually in the medication. The pellets are about the size of a grain of rice, and they're injected under the skin. So once they're in there, there's no getting them out, right? So if your levels go high, you're just going to have to suck it up until it all kind of works its way through, which can take longer than 6 months for your hormone levels to come back into the normal range. So there was one study in particular that really showed the average testosterone level was much higher than what's recommended for women in menopause. So to put it into perspective, the normal range for postmenopausal women in this study was considered to be between 3 and 41. I won't give you the units. I'm just giving you numbers so for some perspective, right? 3 to 41, and up to 38% of the women using the pellets had levels of testosterone over 200. Okay, so this explains why some women who receive pellets develop acne, they lose their hair, they can get an enlarged clitoris, or even a deepened man's voice, because some of them are getting levels of testosterone meant for men. And pretty much every major medical group advises against testosterone pellets, including the American College of Obstetricians and Gynecologists, the International Menopause Society, the Endocrine Society, the European Menopause, and you get the idea. I think every menopause society is on this list of people who advise against the pellets. Okay, so think twice if someone offers you a pellet. So once testosterone is prescribed, generally here in Australia, it comes in a tube as a cream under the trade name of Androfem. It comes with a little syringe that helps you kind of suck it into the syringe so it can help measure the dose. The syringe is a little bit painful from personal experience because it's like kind of hard to get it in there with the air. You know, you just have to really fiddle with it until you get the hang of it. The global statement that I mentioned earlier recommends having a testosterone level blood test done prior to starting the testosterone, and then have another blood test done about 3 or 4 weeks after starting it. And that really is only just to make sure that your levels haven't gone ridiculously high, okay? Because as I talked about before, we want to avoid too high of testosterone levels. We want to get ourselves into what's called a premenopausal physiological level so that we can reap those benefits in terms of the libido. But we don't want to overshoot that, because if we do get an enlarged clitoris or a deepened man's voice, we cannot turn back the clock, right? You're stuck with it. Now, I don't want to scare you, because if we do this properly and we are monitoring closely and we are, using appropriate doses, that is very, very, very unlikely to happen. There are other things that will tell you first that you're heading in that direction, right? So if you start to grow a lot of body hair that wasn't there before, if you start to get a lot of acne, these are signs you're probably getting a little bit too much, right? So again, working with your doctor and monitoring very closely, and we can really minimize the risk of that happening. Look, I wouldn't be taking it if I was worried I was going to get either of those things. And hopefully by listening to me, you can tell that my voice hasn't turned into a man's voice. Okay, so the starting dose is 0.5 ml. It's rubbed into the upper outer thigh every day. Now, this is really important because this is where we know how the drug works, right? If you put it in other places, the absorption can be different, which means that you can get higher absorption or lower absorption. So it might not work as well, or you might get way too much, right? So it has to be in that place. The tube here in our little country town, and I forgot to tell someone this once, and I think they about fell out of their chair or whatever they were in when they found out how much it was going to cost them, because the tube is around $100 here in our little country town. So we're maybe a little bit more here than if you were to get it at some big chemist or something. The tube is 50 mils. So if you're starting on that starting dose of 0.5 mils, and if you stayed on that, the tube's going to last you a good 100 days. So somewhere around $30 a month. And then after a few weeks, you have your blood test. Bloods are good. If your levels are okay, then if you're not having side effects and you think that maybe you're starting to get some benefit, but not a lot, you can increase it at that stage. But keep in mind, it does take 4 to 8 weeks for some people to actually start feeling a difference. And then the improvement peaks at around 12 weeks. If there's no benefit at 6 months, then it just needs to be stopped because it's not really helping. Other than some people who stop it then think, oh, actually, that was helping. Okay, so that's one way of finding out. So testosterone levels fall with age in adult women. So we peak at around 20 years old, and then our levels are about half by the time we get to 40. The lowest point happens when we're around 65 years old. Now, I want to touch on testosterone blood tests because I think there's some confusion here around this. There's a few misconceptions about the test. So doing a testosterone blood test to check for low levels isn't all that useful. So you wouldn't go to the doctor and say, oh, I've got a low libido. Can we check my testosterone? Because it's not going to confirm anything, right? It could be low, but there are women who have really low levels that have normal libido. When I had my testosterone blood test, the levels were pretty much unreadable. But there can be women who have these levels that have no issues, and some like me who do. And some women who have much higher levels who are having libido issues, and some who have much higher levels who are not, right? So it's not a diagnostic blood test for this reason, okay? The only really good time to do the test is just to make sure that we're not giving a woman too much testosterone, or if you're worried, some other kind of weird tumor or something that might be making too much. But in this case, it really is just to make sure that we're not overshooting the mark, that we're keeping her within a physiologically normal range, because we, again, just want to avoid those irreversible side effects that I mentioned earlier. So personally, I've had no issues with the therapy. I have had no acne. I've had no hair growth. I did increase my dose after that first half mil. I went to a mil. I've been on a mil for a while now. My levels have come up beautifully, but still, staying within the range. I have seen some improvements in my libido. There isn't any swinging off the chandeliers or anything like that, but I feel a lot closer to the self that I've known for my whole life. So I'm really, really happy with that. I think we're all happy with that. Now, I do think my mood and my muscles were well on the way to being much better prior to starting the testosterone, so I can't say that I've really noticed any huge difference there. And you know what? It's with the evidence. There's been some really mixed reviews in the literature around mood and well-being in particular. The global consensus statement reported that there's no conclusive evidence for benefit for these, for mood or for bone and muscle health, but they do point out not a lot of studies. We've talked about this before. I'm hoping that the research dollar is getting put here too, because not enough studies have been done, especially around the bone and muscle side of things, seeing how testosterone can help or affect bone and muscle. So hopefully there's some things in the pipeline. Okay, guys, that's it. That wraps up our 3-part series on the Libido Chronicles. I hope it's been useful. I am very hot out here, and I think it's about time for me to get some water into me and get out there and enjoy this amazing day. I hope that you are enjoying the summer if you're here in Australia, the winter if you're on the other side of the planet. And I hope that you're enjoying these episodes. Again, please rate and review. And if you can write me a written review, amazing, because I really love feedback. I love to hear about the things that you guys are curious about, you're struggling with, any of those kinds of things. Love, love, love. You can DM me on one of my socials if you don't want to, put your name out there. I promise I'm never going to call anyone out by name. So yeah, please feel free to contact me and give me some feedback. I hope that you have a good week, everyone. And until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts her medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at opttothrive.com and leave a comment for any subjects you would like to hear more about.